Live from both Baltimore and New York is our next webinar with Susanna Cahalan, author of Brain on Fire, Professor Arun Venkatesan, and Dr. David Benavides.
Hi there. This is Arun Venkatesan coming to you from Baltimore. We're here at the Johns Hopkins Encephalitis Center, and we're glad to be part of World Encephalitis Day. I trust that this has been an exciting day for all of you, and we're now closing with a session on NMDA receptor encephalitis. But before we talk specifically about NMDA receptor encephalitis, I just wanted to take a step back and talk a little bit about encephalitis in general. And I think many of you who have been on the webinar during the course of the day will be familiar with some of these themes, but I think it's worthwhile just covering them so that we're all on the same page. All right. So encephalitis, as many of you know, refers to inflammation of the brain. And that inflammation can occur in several settings. So it can occur in the setting of infection, but it can also occur in the setting of immune or autoimmune conditions. Now, it turns out when you look at patients who come in with encephalitis, that about 40% of them will have infectious causes. And that's been our experience as well when we've looked at patients who have come through our Johns Hopkins Encephalitis Center. About 20 to 25% of patients will have autoimmune causes of encephalitis, and the rest, that leaves about 30 to 35%, will have an unknown cause despite extensive evaluation and investigation. Now, we're going to be focusing on those patients with autoimmune encephalitis, but I did want to emphasize that many of those patients with unknown causes of encephalitis are likely to have autoimmune causes as well, ones that we simply don't know about yet or don't know how to identify yet. And so this category of autoimmune encephalitis is really important to consider in patients who present with signs and symptoms that are compatible with brain inflammation. The other thing I wanted to emphasize at the outset is that this field of autoimmune encephalitis really is still in development. And so although some of us are very familiar with the clinical manifestations and the research surrounding autoimmune encephalitis, there are many in the medical community and elsewhere who really aren't. And so I think it's important that we devote a portion of World Encephalitis Day to talking about autoimmune encephalitis. Now, of the many causes of autoimmune encephalitis, NMDA receptor antibody-mediated encephalitis, it has a variety of names. Some people call it anti-NMDA encephalitis or anti-NMDA receptor encephalitis, is one of the most common causes of autoimmune encephalitis. And so today we're going to be focusing on that in particular. Now, what does this mean to have an autoimmune encephalitis? So what that means is that the body is essentially attacking itself. And in the setting of NMDA receptor encephalitis, this is how we think it happens. So in about half of patients, a tumor is present, usually a gynecological tumor, like an ovarian tumor, or potentially in a man, a testicular tumor. And the body, very appropriately, tries to attack that tumor. So it uses its immune system to try to attack that tumor. And so the body produces antibodies that are directed against that tumor. Now, what can happen some of the time is that those antibodies that are appropriately directed against the tumor actually can cross-react against proteins in the brain. And so when that happens, one can get neurological or psychiatric problems. And that's what we think occurs in anti-NMDA receptor antibody-mediated encephalitis. We think that these antibodies are targeting a protein called the NMDA receptor. And it turns out that the NMDA receptor is on the surface of brain cells, of neurons. And they're on the surface of brain cells in many different parts of the brain. And so when antibodies are attacking those proteins and recognizing those proteins throughout the brain, one can get many different manifestations of disease. So the next question is who gets NMDA receptor encephalitis? And it turns out, like I mentioned, it's actually, we're recognizing that it's a fairly common cause of encephalitis, particularly in women. So the female to male ratio is approximately 4-to-1 in terms of who gets NMDA receptor encephalitis. So many more women than men. And it also tends to affect younger women, and in particular those of childbearing age. And it turns out that it's those women who develop this during childbearing age who are at highest risk for these tumors. However, it also turns out that you can get very young individuals and you can get very old individuals who develop NMDA receptor encephalitis. In those people, it turns out that a tumor is unlikely to be present, and there are probably additional mechanisms that are contributing to the onset of NMDA receptor encephalitis that we haven't quite identified. There is an interesting story that's coming out in the literature about the role of certain infections in NMDA receptor encephalitis, including the herpes simplex virus as a potential trigger for NMDA receptor encephalitis. And if we have a chance later during the webinar, we'll talk about that in a little bit more detail. But that's just a broad overview at this point in terms of causes of encephalitis, which include infections and autoimmune causes. And of the autoimmune causes, a little bit more focus on NMDA receptor encephalitis, what the pathogenic mechanism is, and who typically gets the disease. And so what I'd like to do now is to invite a colleague of mine, Dr. David Benavides, who's a fellow in our Johns Hopkins Encephalitis Center, to talk a little bit more about the clinical manifestations of NMDA receptor encephalitis. That is, how does a patient typically present, and what are the signs and symptoms that can alert physicians that a patient might have this? So, David, why don't you come on over?
Great. Hello, everyone. Thank you, Dr. Venkatesan, for the invitation, and thank you all for participating in today's program. Again, my name is Dr. David Benavides, and I'm a fellow in the Neuroimmunology and Neuroinfectious Disease Division here in the Encephalitis Center at Johns Hopkins. And as Dr. Venkatesan mentioned, I'd like to speak a little bit about what the early signs or symptoms in anti-NMDA receptor encephalitis are. As Dr. Venkatesan mentioned, this disease can present in both young and old men and women, and to some extent, the symptoms can vary based on the age and the sex of the patient. In general, the symptoms tend to be along psychiatric or neurologic in origin. That means that they can manifest initially as memory problems, confusion, and can also involve sleep disorders. But our experience, and certainly the data, would suggest that single symptoms that don't change are rare, at least in cases of anti-NMDA receptor encephalitis. It's much more common that symptoms evolve and progress to involve more systems and more dysfunction. As I mentioned, there are a number of sort of memory and short-term cognitive deficits that can be early signs. Sometimes even a flu-like illness, fever, flushing, sometimes gastrointestinal symptoms can be early signs even before the memory or cognitive deficits. There can be any number of other neurologic symptoms that speak to dysfunction in different areas of the brain. This can be anything from vision, speech, movement, sensory changes, can all be present early in the disease. Symptoms can then progress to involve much more significant and diffuse dysfunction, including movement disorders that's uncontrollable, movements, twitching, tightening of the face, facial area, the arms, the legs, that can be often and very often uncontrollable by the patients. And these can happen and can be difficult to differentiate from seizures, which are also present in the disorder. Seizures being, again, physical movements and abnormal functions that are, again, out of the control of the patient, but are rather due to dysfunction from dysregulated activity within the brain. We know that patients that are subject to anti-NMDA receptor encephalitis also develop what's called autonomic neurologic symptoms, in which heart rate, breathing function can be compromised and can be abnormal, requiring urgent evaluation and treatment to secure those functions as well. It's very common as well for the symptoms to progress to the point of loss of consciousness or coma, in which patients require life support measures in order to sustain life function while the disease is being diagnosed and managed. Now, the vast majority of patients will experience some range or spectrum of these disorders or of these symptoms. It's rare that one single component is the sole type of symptom that persists. Rather, as mentioned earlier, it's more likely that a progression moves from early, vague, non-specific symptoms like flu and maybe some muscle tightening, aches, pains, to the much more life-threatening symptoms that we know this disease can present with.
Yeah, so it can be a very severe illness, as Dr. Benavides nicely illustrated. And in addition to the neurological manifestations which you described, did you want to comment a little bit on the psychiatric manifestations as well? Some
Sure.
of the behavioral changes, the hallucinations, and
Absolutely. The fact that NMDA receptors are the target of this neurologic condition, a lot of functions that have been attributed to NMDA receptors are abnormal in these patients. And as Dr. Venkatesan mentioned, some of the psychiatric symptoms that patients can feel can look like psychosis. So patients can have hallucinations, they can have disorders in which there are delusions or perceptions that they are being attacked, or that they are in danger, or that there are imposters around them. This sort of idea that people have taken over the bodies of loved ones or friends, and it can be very difficult clinically to distinguish these symptoms of psychiatric dysfunction from an autoimmune cause from those of just psychiatric disorder.
Yeah, I think that's a great point, David, that many of these patients will actually end up initially with, in addition to flu-like symptoms, psychiatric manifestations. And so the first stop for many of these patients may actually be in a psychiatrist's office or in a psychiatric institution. And in the past, before we knew about NMDA receptor encephalitis, many of these patients might have been thought to have primary psychiatric disease and might not have been afforded the types of treatments that are now available for this relatively treatable condition. And we'll talk a little bit more about treatment in a moment. So thanks for that. I think the other question that we probably should address at this point is, you talked about some of the symptoms that can arise in these patients, and you talked about how it's unlikely that if you have just one or even two of those symptoms that someone would have NMDA receptor encephalitis, but if this crescendo of symptoms starts to build up, that there needs to be a suspicion of that disease process. So what kinds of tests are done to diagnose NMDA receptor encephalitis?
No, that's a very important question and an important part of the diagnosis of the condition. In someone for whom anti-NMDA receptor encephalitis is being considered or wants to be evaluated, the hallmark of diagnosis is in the detection of antibodies that react with NMDA receptors. Now, that detection can happen on a blood sample or a sample of the fluid that bathes the brain and spinal cord, the cerebrospinal fluid. It's the detection of these antibodies using various laboratory techniques that is the gold standard in the diagnosis of anti-NMDA receptor encephalitis. We know that there are, internationally, there are both research and commercial labs that can conduct these tests, and they're done using various approaches, all targeted at detecting these antibodies in patient samples. There is some, I would say, it's an evolving technique into what is precisely required in order to make the diagnosis, but suffice it to say there are multiple techniques in order to detect these antibodies that are being used.
Yeah, great. Thanks. And so I think at this point we wanted to turn to treatments for just a moment. And so in terms of treatments that are afforded for patients, so once a patient comes in with the signs and symptoms that Dr. Benavides described, and they're diagnosed with anti-NMDA receptor antibody-mediated encephalitis, the question arises, what treatments are available for these patients? And those treatments really fall into two different large categories. So one would be treatments that target the immune system and try to quiet down the immune system in order to limit the effects of the antibodies. And then the second would be symptomatic treatments. That is, what can you do to reduce some of the symptoms that the patient may have? And we'll talk a little bit about the immune component now, and if we have a chance a little later, we'll talk more about some of the symptomatic treatments that we have. So in terms of the immune therapies that we are able to offer patients who come in with acute episodes of NMDA receptor encephalitis, we talk about first-line immune treatments and kind of second-line or more aggressive immune treatments. And so the first-line treatments really are comprised of three different things. So one is steroids, all right, and steroids, as we know in many conditions, both neurological and otherwise, are actually quite good at suppressing inflammation. And that's the reason to use steroids. They kind of very broadly will suppress any inflammatory process throughout the body and can be useful in the acute setting of NMDA receptor encephalitis. There are two other approaches that more specifically target antibodies. And the first approach is called intravenous immunoglobulin. It's an IV infusion of antibodies that are collected from healthy donors. And although we're not quite sure exactly how this works, those pooled antibodies from healthy donors actually help to quiet down the immune response and may do so by directly interacting with the abnormal antibodies that are present in patients with NMDA receptor encephalitis. And then finally, the third of the first-line agents that we would typically use is an approach called plasmapheresis or plasma exchange. And what that involves is something that is kind of akin to dialysis, where we're basically trying to remove the abnormal antibodies from a patient's blood and either flush them out or replace them with healthy antibodies. And that's something that's typically done over 5 to 6 sessions, and it's a procedure that's typically done in the hospital, and that requires placement of a catheter. And so it's a fairly involved process, but is something that we and others have found to be quite effective in the setting of acute NMDA receptor encephalitis. So those are the first-line agents, and then if patients require, and most do, additional treatments beyond those first-line agents, then we talk about medications that were originally conceived for cancer and for suppressing, for targeting cancer cells, but that are also useful for suppressing inflammation. And those would involve agents such as rituximab, which is an agent that targets certain immune cells and that can reduce antibodies and the interaction of immune cells in the disease, and also more broad-spectrum chemotherapeutic agents like cyclophosphamide, which kind of knock down the immune system in general. So those are general approaches to targeting the immune system in patients with NMDA receptor encephalitis. I think the bottom line is that we have a number of options, and so when patients come in, we think it's important to diagnose early, to treat early, and to be really aggressive in terms of treatment. And we've certainly found, and others have as well, that this is important for improving outcomes in these patients. So with that, I think we'd like to turn to our guest and a patient, Susanna Cahalan, who's going to be joining us to talk a little bit more about the patient experience and perspective of NMDA receptor encephalitis. I think as many of you know, Susanna is the author of Brain on Fire and has been a fantastic spokesperson for the disease, and we're absolutely thrilled to have her join. So give us a moment and we'll get her on the line. Hi, Susanna. It's a pleasure to have you join.
Thank you so much for having me here. I'm so excited about today.
Of course. And Susanna, I'm joined by Dr. David Benavides. He's one of the fellows in our Johns Hopkins Encephalitis Center.
Hi, so nice to meet you.
Nice to meet you.
So we've just been introducing the topic of really autoimmune encephalitis and then NMDA receptor encephalitis as well. And I think that what we were hoping to do at this point is really to get a patient's perspective on the disease, and we couldn't think of a better patient to get that perspective from than you. So I'm hoping that you can kind of take us through your journey and really to start at the beginning. So can you tell us a little bit about how this all started for you?
Sure, and I think it's really important to kind of start from that beginning because it begins so subtly. And it's so often missed early on, you know, and I definitely missed it because my initial symptoms, again, looking back now from recovery, I can say that it started with kind of basically feeling off and not like myself. So kind of the first symptom that I think I trace back to is this feeling that I had bed bugs in my apartment. And so I remember I was obsessed with this idea that I had, you know, bed bugs. Even when people told me you don't, I couldn't stop thinking about it. It was something that just invaded my thoughts. And it doesn't sound that strange, but it was out of my personality. My personality is not typically like that, to kind of really get obsessive about that. It was a little odd. And then, you know, I started to also get kind of independently kind of physical symptoms too, which I did not connect. And I was very lethargic. I had headaches. I couldn't really concentrate at work. It's almost as I was just sleeping a lot. I was almost as if I had a flu. I had a lot of flu-like symptoms. And that was kind of the beginning of everything. Later it changed drastically, but at that first point, it was very easy to kind of discount and say, you know, I'm just feeling under the weather, or I'm not feeling like myself. And so it was very easy to miss at first.
And over how long did these initial symptoms evolve?
I would say that from the bed bugs and through those flu-like symptoms, about 2 weeks. I would say that would be fair. And it was so interesting because there seemed to be a moment where it switched in the opposite direction, and I was manic. I had so much energy. I wasn't sleeping at all. I wasn't eating. You know, I was going through these kind of fluctuations of emotions, and it was strange how fast that happened. There was almost like the switch there. Even though there were signs before, like I started acting a little paranoid, a little suspicious about things that didn't really make sense. And then something switched, and I really could not regulate my emotions. I would go, within a matter of minutes, go from crying hysterically, then laughing. And as a person going through this, you're trying to make sense of why am I crying? Why am I so happy? Why am I, and you try to make sense out of your environment. You think, okay, well, my job's really hard. maybe that's what it is, or, I'm 24 and I'm in a new relationship. Maybe that's why I'm feeling so strange. So you kind of try to make sense of it using your environment, but it didn't make sense. It rang hollow for me. I knew something was wrong, but I didn't know what was wrong, and I didn't know what was causing me to behave in such strange ways.
So it sounds like this evolved over a few weeks, but was clearly very different than your prior experience of yourself.
Right. Yes. Exactly.
And that it was really hard to kind of rationalize why you were feeling the way that you were.
Exactly.
So then what happened?
So I would say with these kind of new symptoms, it became clear that something was really wrong. And there were a lot of speculation on my part and my family and friends' part. I thought that I was suffering from bipolar disorder. And, my mother thought I was having a nervous breakdown. I mean, there were a lot of theories as to what was happening to me. And then I had my first seizure. And that kind of brought it in, which I think for many patients, because not all patients obviously who have autoimmune encephalitis have seizures, but a good chunk of it, about 70% have seizures. And for me, that really kind of saved me, I think, because after that, it was my friends and family were saying, this is a neurological, something's wrong here, like seriously wrong here. And after that first seizure that I had, my behavior changed drastically. I mean, it went from being moody to being psychotic, initially, like almost immediately after that first seizure.
So it sounds like there was initially thought that this could be a primary psychiatric condition, yes, as occurs for many patients with NMDA receptor encephalitis, and as we alluded to, that the psychiatric symptoms can actually be very prominent and can be very early in the disease. But as you mentioned, once that seizure occurred, then it seemed like we were taking this away from a psychiatric illness and placing this more in the basket, shall we say, of a neurological illness.
Well, you would get that that would have happened, but in fact, at the time, so that was my kind of my family's reaction to the seizure, but the clinical reaction to my seizure, there wasn't really a reaction because it was never recorded on an EEG, so it was basically my parents' word, and there were some thoughts that perhaps this was, post-ictal psychosis, maybe this was a drug-related thing. I mean, the seizure actually wasn't really an indication for the doctors I was seeing then that this was a neurological disease. In fact, the first in a series of doctors I saw said I had, thought one of her rule-out diagnosis was bipolar 1. And then as the symptoms increased and I got even more paranoid and started to actively hallucinate, have delusions, that changed to schizoaffective disorder. So even with those seizures in my medical history, I still was very much placed in that psychiatric, that it was, people thought that I was suffering from a psychiatric disease at that point.
And so can you tell us a little bit more about interactions with the medical community at that point? Who were you seeing and how were they treating you? What were they using, medications or other approaches?
So, okay, so I'm going to go back. Yeah. So when I first had those initial symptoms with the moodiness and the lethargy, I also had a very physical symptom, which was one-sided numbness, which for me was very scary because no one likes to hear about one-sided numbness in the body. And so there was worries that I had a stroke or this was MS. So I went to a neurologist who did workup, and the workup was clean. And he just saw a few slightly enlarged lymph nodes in my spine, which led him to believe this is possibly viral, maybe mono. So that was my first diagnosis. And I was just told, just stay, just kind of drink a lot of fluids and just stay off your feet and just, it will pass. And then after I had my first seizure, I returned to that same doctor who, again, using that very clean workup, again, on paper, I'm a healthy person, comes to the conclusion that I am suffering from alcohol withdrawal and that I am working too much and basically that it's stress-induced, that all of this is stress-induced. So that was the second diagnosis that I received. And at that point, I was placed on anti-seizure medication. But at that point, I was also becoming very much more psychotic. So I was attributing my emotional disturbances and the strange new person I had become to the antipsychotic medication, the anti-seizure medication. So I didn't want to take it. And I was still having seizures. Even with that seizure medication, it wasn't working. I was still having seizures. And then, in the midst of that, I also went and saw a psychiatrist under my own prodding, because I thought I had bipolar 1, and she confirmed my suspicion that I had bipolar 1 and diagnosed me with antipsychotics. So that was all before I even went into the hospital. I already had a multitude of diagnoses and was medicated as well.
I think this reflects a lot of the confusion that has surrounded this condition and related conditions that can cause encephalitis. It really highlights that, and highlights, I think, the conundrum that patients are placed in as well. Can you talk a little bit more about maybe some of the frustrations that you and your family were feeling at that point?
Oh yeah, I mean, the frustration lasted a long time into the hospital. But prior to the hospital stay, my parents were insisting that I be placed in a hospital. First of all, I was becoming a danger to myself and others. I was jumping out of cars. I was behaving erratically. They couldn't control me. But also, I was having seizures, and I was having more and more grand mal seizures. And so they were trying to get me into a hospital setting, but not a psychiatric hospital. And they were, my mom wrote a list, a long list of all my symptoms, saying, she's just on alcohol withdrawal. This is not this. This is not that. She needs to go into a hospital, and she needs to be monitored. She needs to be taken care of. And we got a lot of, fight about that. The doctor did not necessarily want to, he didn't necessarily believe that I needed to be in a hospital. So she really had to advocate. And I was not advocating for myself. Now, I wasn't feeling any of this frustration. I thought that I had a psychiatric disorder. In fact, at one point, I thought I had borderline. I thought I had multiple personality disorder. Oh, and I told the doctor that I had multiple personality disorder. So I wasn't doing myself any favors. The people who were doing me the favors were my family and my friends and my boyfriend. They were the ones who were saying, no, this doesn't make sense. And they really fought, and they really kind of pushed to get me into the hospital. And luckily, because of those seizures, I ended up on an epilepsy unit. Not a psychiatric unit, which is where my doctor really wanted me to go.
Well, thank goodness that you had such strong advocates.
Yes.
One can only imagine what happens to patients who don't have that kind of support and advocacy.
Without them, I wouldn't be here now. I know that. Because again, I could not be that person for myself at that point. I was my own worst enemy then. So, I needed someone to rally for me. And I was very lucky on so many levels, but I'm very lucky on the level that I had people who cared for me, and also who were able to say, we know this, her baseline, we know who she is. This is not who she is. And they felt strongly about that. And I was lucky that I had people who knew me in that way and felt that they could fight for me in that way.
Yeah. So you ended up in the epilepsy unit.
Yes.
So can you tell us what happened from there?
Sure. So so finally, my mom, with that piece of paper, finally convinced the neurologist to admit me, and he called NYU, which had a bed open. So we rushed over to NYU, and by some stroke of luck, I had a seizure in the waiting area, which brought me immediately up. But anyone, I think many people who are watching this probably have had to wait for a bed at a hospital, and it's a horrible, hours long kind of fiasco. But I didn't have to go through any of that because I had a seizure. So I was ushered immediately up to that open bed. But that bed happened to also be in a four-person room. So there are 3 other patients in the room. And someone who's going through psychosis, you probably should not be in a room filled with 3 other patients, because every sound, every creak, everything that was going on, any movement, for me, was negative. It was everything. Everyone was out to get me. Everything was heightened. All my senses were heightened. So it was a very bad place for me. And I started to devolve very fast and became even more actively psychotic, and believing these delusions that my father had killed my stepmother, and that the nurses were turning into people and playing tricks on me. And some of these things I remember now, and some of these things are in the actual medical history that I read, while I was writing my book. But it was a very hard time for everyone, including myself. And I felt I didn't want to be there. And I felt that, I had people were out to get me, and I wanted to get out. So I tried to escape multiple times and had to be sedated. And, at that point, I was very much a problem patient. And again, everything is clean. All the records they get from my neurologist, they're clean. All the tests they're able to do, even though they can't do many tests because I'm so psychotic, but the tests they are able to do, they're normal. So it was, I was problem patient number 1, and, they didn't know what to do. And They finally moved me to a solo room, a single room. And it was strange because my behavior improved, but not probably because it was improving. It was because I was actually heading into catatonia. But it was a kind of coincidence that once I was moved out of that 4-person room, I wasn't as actively psychotic anymore, but I was kind of not anything anymore. I was not really engaging with the world. So that was, I think, for the doctors then a sign that there was something going on here. But there is something called catatonic schizophrenia, right? There is, so that was also something that they were thinking is maybe she was going to a catatonic stage of schizophrenia. So the idea that it was a psychiatric condition was still very much there. However, neurological signs started to crop up around that time. And I think, you talk about how the psychiatric presentation can kind of overshadow the neurological one. And that's definitely the case with me because I was very overtly psychotic. And that was the first thing everyone saw. But if you kind of dug a little bit deeper, you saw that there were cognitive issues. You saw that there was heart rate fluctuation, the seizures, obviously, so, there were other things going on. And I think that the doctors who I was seeing were only able to see that side when I started to edge in catatonia.
Yeah. So you mentioned the catatonia. Can you also describe some of the other neurological symptoms that were progressing at this point?
Sure. So even prior to edging into going to the catatonic stage, I was doing abnormal movements a lot. So I was smacking my lips a lot. I mean, so much my whole face was chapped and smacking constantly. I was leaving my hands at these kind of strange angles and would leave them out for long periods of time. It's unnatural angles. I actually just saw, it's hard for me to watch, but I have a lot of video of myself in the ward because I was on the epilepsy unit. And so they had video cameras and I would just lie straight as a board, really stiffly straight as a board on the bed. And, I was having also, which is strange, and no one's been able really to figure it out, but I was having these almost looked like panic attacks, but it was like this, I couldn't breathe. And I think that there was something going on with the brainstem or something going on then in terms of not being able to breathe. By the time, people thought I was having a tantrum or, I was misbehaving, but I think there was actually an inability to breathe at that point. So these things were happening. I also was having fluctuation in my heart rate. So my heart rate would go really high and then really low. And I was actually put on blood pressure medication at that time, which was strange because I'm not walking around. I'm sitting in the bed, but my heart rate's going all over the place. So there are all these kind of signs that are emerging and start, or maybe perhaps were there from the beginning, but become more obvious once the psychiatric presentation starts to wane a bit.
I imagine with this constellation of symptoms that you're describing at this point, this must have been terrifying for your family, for certain, and potentially for you as well, if you were able to recognize some of these symptoms.
At that point, I was at that point, I don't remember anything. So, yeah.
Family then.
This was, yeah. I mean, I think my mom, when I was interviewing her for my book, said that when she walked in one day and I started to lisp, and my tongue was hanging out and I couldn't really form words and I stopped really talking. That was for her the scariest, beyond even the psychosis, because that was measurable change in the wrong direction. That was getting worse. And that was clearly, I mean, there was just no doubt about it. This was getting worse. And that was very scary for my family were those times, because I went from, being psychotic, but still able to speak and talk, and to not being able to talk and hardly, really hardly even being able to write. And it was a short period of time. We're talking, I was in the hospital when I started really becoming catatonic. It was about 2 weeks into the hospital.
Wow.
Yeah.
So this really progressed rapidly.
Very, very rapid, very rapid.
So can you tell us about what then eventually led to a diagnosis?
So, there are some indications now that this is a I think that, there was a movement towards, okay, this is some kind of neurological, but we don't know. And, blood, at that point I was able to do a lot of tests, because in that catatonic stage, they actually could do tests on me as opposed to when I was psychotic. And they saw slightly elevated, white blood cells, slightly, and then in my spinal fluid. And, there were some that was basically it. I think everything else was clean, and all the blood tests that they sent, all the panels, autoimmune panels, all these panels, they came back negative. So that was when a man named Dr. Najjar was called into the case, and he had actually had a history of treating patients with autoimmune diseases, and that were probably not even yet discovered. There was one patient that he had, a young boy who had seizures, and he wasn't responding to medication, and you're talking 100 seizures a day, and they were doing resection surgery, so they're taking parts of his brain out to kind of, get the seizure focus and take it out. But that seizure focus would move. So every time they would take a piece of the brain out, that focus would move. So Dr. Najjar suggested perhaps this is, perhaps we should try autoimmune therapy. And he responded, and responded really well to it. So I think that was going through his head when he had heard my case. And so he saw me and came in and actually did a beautiful health history. I mean, and I wasn't able to communicate with him at that time. So he was kind of interrogating my body at that time, but he was talking to my parents. And really you see the whole basically life history of the disease. You see the bed bugs, you see the numbness, you see all those things in his notes. But then the kind of breakthrough happened when he asked me to draw a clock. And it was, just a simple test, but I drew all the numbers on the right-hand side of the clock, like, the 12 o'clock landing where the 6 o'clock should be. So half clock, and so, but that showed to him that the right side of my brain, which is responsible for the left field of vision, was impaired in some way. And that's when he thought of that boy with those seizures and thought, okay, this might be an autoimmune reaction. And at that point, he sent my fluid off to University of Pennsylvania, which at the time was the only place that tested for it. And it came back positive for anti-NMDA receptor autoimmune encephalitis. So it was interesting after all those tests. And I was told at the totality of my stay there, it probably cost about $1 million in terms of, insurance stuff, but, through insurance companies, about $1 million to treat this. With all the tests and everything. And it really came down to a piece of paper, which is just miraculous. It's amazing. So yeah, but so we got that, we got the name of the disease, but at that point, this was 2009. It was unclear nothing was written about it that we could see online except for really hard to understand medical journal stuff. A study out of Japan. There wasn't much out there. And so we didn't really know. We heard this scary name, Anti-NMDA Receptor Autoimmune Encephalitis, and we think, what? I know my parents were like, what is this? What are we facing here? And at the time, the numbers were actually pretty. They were happy to hear these numbers. I mean, they said that with proper treatment, there's a high chance of recovery. And at that point, he thought, I could probably regain about 80% of my cognitive abilities, which my parents were at the time were thrilled with that. That was a very exciting thing to be told. So they were very happy in a way to get that diagnosis, but it was also really scary because there was just no information about it out there.
Sure. So very fortunate that even though this was really early days in terms of recognizing an NMDA receptor encephalitis, that it was recognized and that you received a diagnosis and that you then underwent treatment. And maybe you could tell us a little bit about treatment, but I think the other thing I'd like us all to hear a little bit more about is kind of your course since then. Yes.
So, the treatment was fairly simple, and, steroids, a plasmapheresis, and IVIG treatment, and lots of IVIG treatment.
Those are the first line treatments that
I only received first line treatment. Steroids are a miracle drug, but they're also a sledgehammer drug, and they're not an easy drug. And I think a lot of people who have gone through encephalitis and needed steroids, or any disease that you need steroids, steroids is used in so many diseases. It's a very harsh drug. It affects your mind, and it affects your body. It affects your body in a serious way. It affected everything down to my hair. I remember when I was on steroids for a year, and I remember my hair was just it was just so coarse, and everything. I put on about 45, 50 pounds, and I was, my face, I got that kind of, what is that called? It's called
moon face.
Moon face. I had that, people didn't recognize me. It was really hard. Just being on the steroids, and it was hard to say where the fact that my mind was kind of repairing itself, and the steroids, the antipsychotics. I was on a lot of, it was kind of very hard to say, where does the illness begin and where does the illness end, and where did the treatment begin in terms of how it affected me. But the recovery was the hardest part for me out of this whole experience, because it's that experience of living life, thinking you're one way and thinking being comfortable in your, as anyone it can be, but, comfortable in yourself, and then coming out of a disease that you don't remember and you don't understand, because I didn't understand it I had no idea what it was. And coming out of it and not feeling like yourself, not feeling comfortable with yourself, not feeling comfortable with other people, everything that you think about yourself. Like, I thought I was an outgoing person who could talk to people. That was just robbed from me. I couldn't. That was no longer me. And so you're navigating in this world without yourself anymore. I mean, you're a different person. And that was so hard for me. And from the, first moments when I was out of the hospital where I could hardly walk and I couldn't really write, to, 3 months, 4 months into treatment when I'm about 80% myself, and I find it hard to even order a coffee at a coffee shop because it's painful and you're scared and you're anxious. What if you mess it up and you don't feel like yourself? And also, a big thing that was happening during that time is there were things going on in my head. I was there, but I couldn't verbalize it. It almost was trapped, in the back of my head, and it couldn't come out my mouth or even being expressed in my emotions in my face. And so you kind of live this life where you're just smiling and people think that that's what's going on. But there is so much internal life going on, but you just can't translate it into action or into words. And that was so frustrating and scary, because you think, will I ever be the same again? And in many ways you won't,
I think what this points to is sometimes a bit of a disconnect between what clinicians and physicians feel in terms of recovery and what patients do, because the data suggests that patients with NMDA receptor encephalitis, the vast majority, 80+% of patients, will actually have a tremendous recovery. Now, what does that really mean, though? When a neurologist says, "Oh, this is tremendous recovery," well, what we mean is, well, there are no more hallucinations. There's not significant cognitive difficulties. That the patient is able to maybe get back to work, et cetera. But there are a lot of subtle things that I think we don't routinely screen and test for that can really severely impact the patient.
Oh, I think undoubtedly. I mean, good prognosis, what does that really mean? I mean, it doesn't mean a return to the person you were before. And and reconciling that you perhaps might not come back to the person you were before, it can be extremely depressing and difficult for people to deal with. And, of course, understandably, especially, I remember, it took me, I would say, in terms of full recovery, which is, I still don't know if it's a full recovery. It's so impossible to say, but, about 1.5 years. And throughout the whole thing, I wasn't very contemplative. I didn't really want to think about it. And so I never really had real serious questions, like discussions with myself as to, am I really, am I really here? Only later when I was writing my book did I actually have those conversations. Did I force myself to have those conversations? But I remember I think writing, you access a lot. Probably, if you have difficulties or you're not fully there, you'll see it in your writing. And I remember seeing it in my writing and being able to see, okay, well, I'm not here yet. I still have a way to go, and not really wanting to see that. But it's almost when you're writing, it's just there. I mean, you have to access such a deep part of yourself and so much of your mind. Even if you're tired and you're not really feeling like writing, you'll see it in your writing. But when when your brain is recovering, you see it in your writing. And that was really hard to be able to even trace the course of the illness through my writing. Was really, really difficult, because that was something I've always been. I've always been a writer, and then all of a sudden to think maybe I won't be a writer again, that was really hard.
Wow. I mean, that was really such a deep part of your personality and your individuality, the ability to write and to write fluently.
Right. Exactly. Yeah. And I think that's what happens to a lot of people with any sort of brain trauma, is that things that you thought defined you suddenly aren't there anymore. And so then who are you? That's really, it's a hard question. And it's something that many people have to face. And it's like, who am I? Who is this new person? And where does that fit in my life now?
Can I ask you to maybe share with those who are listening and who are maybe recovering or trying to recover from NMDA receptor encephalitis or related encephalitides. Share some advice that you might have that might help to kind of sustain them during this, as you mentioned, very difficult process of recovery.
I think, one of the things that was something that I didn't necessarily utilize enough, but is really important, is to just do things. I sat around a lot. I watched TV. I just kind of, people didn't realize, my family didn't realize that it was important to keep that mind active and get it. I mean, I did certain things on my own. I started studying for, a GRE test. I started kind of doing certain things to kind of challenge myself, and started writing a little bit. But I didn't really I kind of regret the fact that I had this opportunity to take on a new project, to try. I mean, it might sound silly, but to try sewing or try and learn a new language, it's almost like challenging yourself during this time when you need that challenge most. And a time when you'll feel so proud that you've done it is so. I mean, I think it's so important to do things, and whatever those things are. Maybe it's go for a run, train for a half marathon, or who knows, and whatever whatever you think you would like to do. I think this is a time to really get that confidence up, that you can do something, that you can be a part of something, is so important. It's so important during this time, because it's just sitting around and waiting for your life to return to itself. It's just not the way to do it. It's in a way, you just have to kind of, you want to feel like you're climbing a mountain and that you're in charge. And to do that, I think taking on some kind of challenge or project is so important. And I think that my challenge and project was writing this book, and that was my mountain. And I think that writing was really cathartic for me. And it's because I'm a writer, but I think that for many people, it can be extremely helpful to understand what you went through writing as well. So if you're inclined to that, I also would recommend writing about your story and sharing your story. That's been incredibly, it's been a gift for me throughout this whole thing, and really got me through. I didn't realize when I was writing the book that I was still recovering. And so it was almost a way of, getting myself out there and getting myself doing something and being proud of something, and that was really helpful. And I think that everyone can have their own version of that.
Well, thank you so much for sharing that perspective and for sharing your story, both today and through your book. And I should mention, for those of you who don't know, that there is a movie that's going to be coming out. I think filming will be starting in a couple of months.
I think they say spring or summer.
Yeah.
So, yeah.
Well, that will be really exciting. I know that from our conversations that you don't have much a significant role in that, but I think we're all excited to kind of hear and see how that develops.
Yeah, I'm excited.
And maybe a little nervous.
Yeah, very. But it's amazing. Never thought that would happen. So it's amazing.
Yeah. Is there so as we're celebrating World Encephalitis Day, is there anything else that you wanted to share with the audience before we conclude?
Yeah, there is a race in honor of Florence McDowell, who passed away from autoimmune encephalitis, and it's a wonderful race. It's in North Carolina, and it's March 7th, I believe, in a couple weekends. And if spreading the word about World Encephalitis Day and helping another, kind of great opportunity too. I would love to share that with people as well. That there is going to be a race in honor of a girl who passed away from autoimmune encephalitis, called Florence Fourth. So.
Thank you for sharing that. They are a wonderful and resilient family.
Amazing.
Really trying to do what they can to help others in their situation.
I mean, that is, to me, an incredible reaction to a trauma, right? And to the most horrific thing that can happen to a parent. To actually say, I want to help other people, it's amazing. I mean, that is incredibly, there really aren't any words. I mean, I just find them so inspiring, such inspiring people.
Yeah. I agree. Thank you so much. It's been such a pleasure to have you join us today.
Oh, thank you so much for having me, and I'm happy World Encephalitis Day!
Yeah. You too. All right. I think we're coming to the end of the festivities, at least online, but that doesn't mean the festivities can't continue offline.
I also want to say one quick thing too. I want to thank the Encephalitis Society for putting this all together. They are an incredible organization. I'm so proud to be an ambassador. And I'm just blown away by what they've been able to do with this Thunderclap campaign and spreading the message. So thank you so much, Encephalitis Society. You guys are an incredible organization.
Thank you, Susanna.
Thanks.
All right, take care.
Take care.
Okay.
Bye.
Bye.
So during the discussion, there have been a number of questions that have come through, a number of which you actually addressed during your chat, but I did want to ask a few that have come through. For Susanna, as a journalist, how do you feel the media regards and reports on encephalitis?
I think there's been a wide swath of reactions because it is such a, I work for a tabloid. It's such a tabloid subject, right? Typically girl goes crazy, So there are ways where it can be kind of overly sensationalized, where it's an already sensationalized story. And it's happened to me. I've seen my story taken in context that I have not been happy with. But overall, I feel that I've been pretty happily surprised, not surprised, but happy with the coverage that and the thought that's put in. It's a complicated subject, and it's not an easy one to report. It's complicated neuroscience. We're talking about the kind of cutting edge of our understanding of the brain, and I've been very happy with the way most of the time that it's been covered in the media. And I've been very happy with the general interest in this disease in the media. And I think it shows how, not only is this disease interesting in and of itself, but it's also fascinating about illuminating what happens in other types, perhaps what's happened with other types of psychiatric disorders, and also what happens in a healthy brain. So it's in terms of just kind of neurologically speaking, it's exciting. It's an exciting disease to be a part, and I think that the media has reflected that.
Thank you. It looks like comments.
I had a comment from Mark. He says, I have voltage-gated autoimmune limbic encephalitis, but our stories and how it began and progressed sound very similar. I came out of the hospital in October of 2014. Thank you for sharing your experiences. You look and sound great.
Oh, thank you. I hope he or she. I hope he's doing well. I hope you're doing well.
Great. And there was another comment or question, rather, is have you experienced a relapse in your condition?
I've been very lucky that I have not. There are, I think, what was it, 50? I think, the numbers have gone down, but about 15% chance of relapse. Is that?
Yeah, it's reported anywhere from 10 to up to 20% that patients will have a relapse within a couple of years.
See, it's scary, and that's something that, I've had scares where I've had numbness on my left side again, and then been very scared or had vertigo. I had vertigo and was very scared, and hysterically crying. Because and then all of a sudden I'm crying. Oh my God, my emotions are out of whack. Oh no, but obviously you're reacting because you're scared and you're crying, and that's a normal reaction. But you start to think, oh my gosh, this is an oversized reaction to something so minor. So it's something that does follow me around, but I've been lucky enough not to have had to experience the relapse. So I'm going to knock on wood somewhere. Where's wood? Okay. Anyway.
I see a picture frame back there that you might be able to
use.
Yeah. So that's really fortunate. And like you mentioned, it is the minority of patients, it looks like, who have relapses, at least in the short term. I think what we really don't yet know enough about is the natural history of NMDA receptor encephalitis. That is, what happens to patients over long periods of time. Since this is such a newly and recently described disorder, we're not going to really have that information for a number of years. Those studies are now ongoing to look at the natural history and the progression of the disease. at least from our experience at Hopkins, the majority of patients do not have relapses, at least within the first 3 years. I have seen a couple of patients who had an episode over a decade ago that clearly, in retrospect, was an episode of autoimmune encephalitis that wasn't recognized as such, that then did okay for a number of years, had a second episode maybe 5 years later, again, wasn't recognized as such, and then have had a third recent episode, and now it's clear that all of those episodes really represented flares of NMDA receptor encephalitis.
They've never properly treated it, which is underlying. You know, it's interesting because I had a blood test done recently, and I still have titers in my blood, which, you know, I still have antibodies in my blood, which is scary, I guess, to say that even now I'm, you know, this is 2009, so, you know, I'm far out of the disease now in terms of that, but I still have antibodies in my bloodstream. So that's kind of a little scary, I would say.
I think that is one of the questions that came up, isn't it? What was somebody, and Dr. Benavides will pull this up.
The question is coming from Sarah in England. The question is, how long do antibodies and anti-NMDA show up in the blood in an untreated person?
Yeah, and so that's a little bit different than your situation, where you've been treated with first-line treatments, but really the answer to that is we're not entirely sure. What may be more important than following than looking at antibodies in the blood is looking at antibodies in the spinal fluid, because antibodies in the spinal fluid obviously would have direct access to NMDA receptors on brain cells. But even that may not be a great metric for disease activity, because we've certainly followed patients out for a number of years who have antibodies in their spinal fluid, but who are really back to their baseline as far as we can tell by all measures. And so we don't really yet understand how to correlate those titers of antibodies, particularly the ones in the blood, with levels of disease activity.
From what I've been hearing is that you would not treat a disease based on there would not be a treatment based on titer, especially in the blood, right? So that it's about symptoms and
Absolutely right. We certainly wouldn't treat based on antibodies in the blood, and we certainly at Hopkins we would not treat based on antibodies in the spinal fluid either. I think you're absolutely right that listening to the patient, carefully examining the patient, in order to understand how they may continue to be impacted is, I think, the real key to determining whether additional treatment is necessary or not. Yeah.
A number of questions have come through regarding the, I guess how one acquires the disease or etiology, and I'll paraphrase it. So one question is how do you acquire anti-NMDA receptor encephalitis? And then another linked question, true or false? Those with anti-NMDA receptor encephalitis have had some form of cancer at some point.
Oh, right. So yeah, these are interesting questions. So we talked at the beginning about the link between cancers and NMDA receptor encephalitis. And the fact that up to a half of patients with the condition. What's that?
I had melanoma.
You had melanoma.
I did.
Mm-hmm. Which is interesting in and of itself, because it's not one of the typically described cansers associated with NMDA receptors.
Also, this was 2001 that I had melanoma. So we're talking 8-year difference in terms of when I was diagnosed with melanoma and NMDA receptor.
I think what is and again, we don't know the answers to this, but what the field is moving towards is that there may actually be several different mechanisms that can result in the generation of NMDA receptor antibodies, first of all. So one of those mechanisms would be a tumor like an ovarian tumor or a testicular tumor. Another mechanism may be damage to the brain via, say, herpes simplex encephalitis, and that the generation of antibodies per se may not be enough to cause the disease, that there may need to be additional things that happen to the patient in order to actually cause the disease. And one of those may be kind of a systemic infection, a flu-like infection that allows antibodies from the blood to get into the brain and access those brain neurons to cause disease. So I think at this point, I would be hard-pressed to say that everybody with NMDA receptor encephalitis either has or has had a tumor at some point. Although one caveat to that is that it probably only takes a very small burden of tumor cells to cause those antibodies to form. And so you may not actually ever identify those tumors which are being targeted by the antibody and really being kept in check by the antibody. And so the fact that you have antibodies against the tumor allows that tumor to remain really small and difficult to detect. And so I think we can't rule out the possibility that there may be a few tumor cells that are present in patients, even in those in whom we do all the tests we can do and can't find a tumor. There may still be a few cells that are resulting in generation of those antibodies.
It's really interesting.
Yeah. Other questions?
There are a number of questions that have come through regarding what kind of research is being done for patients, either who are suffering from conditions in which an antibody, like the anti-NMDA receptor antibody, is detected, or for an encephalitis for which there is no detectable etiology.
So I think we can talk about a few things, but since we have Susanna on the line, clearly one of the important areas of research, so one we highlighted, which is what's the natural history of the disease and what really is the risk of relapse over time and what is the degree of recovery of patients over time. And that is being done. A second is really looking carefully at the neurological and psychiatric sequelae, the consequences of the disease. And I think as a field, we haven't been great about doing that carefully in patients until pretty recently. And so a number of groups, including ours, for example, we've set up a multidisciplinary center here at Hopkins that includes not only neurologists and neurointensive care physicians and laboratory folks and immunologists and infectious disease people, but also those who specialize in rehabilitation and neuropsychology. And so we think by bringing all of these people together and following these patients in kind of a prospective manner, very carefully over time, that's really the only way that we're going to be able to understand the true consequences of disorders like NMDA receptor encephalitis and related encephalitides, so that we can then target treatments and therapies that will help bring patients closer to their previous self, their prior self, their definition of themselves. And so those are a couple of things on the kind of clinical research front. David, maybe you want to talk a little bit about some of the laboratory research that's ongoing as well, some of which you're involved with.
Great. Thank you for the opportunity. So as Dr. Venkatesan mentioned, I am very interested in how these antibodies are actually causing the dysfunction or dysregulation of the brain cells and the connections between them. Currently, the field, the scientific field, uses antibodies that are derived from patients that are suffering from the disorder to use in the research laboratory to test how neurons respond, how brain cells function, and even trying to, and have been successful, groups have now been successful in generating animal models in which the antibodies are introduced into animals, and we can observe some of the sort of correlates in an animal that one might expect that these antibodies and changing the way the brain functions might have.
Meaning neurologic and behavioral correlates?
Yeah, these animals can recapitulate some of the sometimes movement, sometimes memory, sometimes maybe even altered sensitivity to stimuli that we see in patients suffering from the disease.
And that's not necessarily a stretch, because these NMDA receptor proteins are so integral to brain cell function that they have really been fairly well conserved over many species. And so many species utilize similar mechanisms of NMDA receptor signaling and intracellular cascades. And so it's not surprising then that if you introduce the antibody into an animal, that you may see some neurological or behavioral manifestations.
Are you using mostly mouse models, or is that?
Yeah, the where the field is now is using mouse models in which the antibody has been introduced. But I suspect that as we get better tools, better reagents. I anticipate, as has been our experience with many lines of research, is that as the tools improve, the kinds of animal models in terms of complexity can also increase. So maybe even into non-rodent animal species as well.
Well, the other aspect is that, you know, we at Hopkins and many other groups are really interested in stem cell technology to develop really more human-based models of disease. And I think that that's something that we're doing as well, is trying to determine how to utilize, you know, stem cells and neurons derived from them to recapitulate some of the aspects of NMDA receptor encephalitis. And we think that's important too, because although these proteins are conserved throughout many species, there's a limit to what one can learn from small animal models. And I think that you know, research that utilizes human-based tissues is clearly going to be important as well.
Especially when you're talking about complexity of, you know, behavior and personality changes. You know, you're not necessarily going to see that direct correlate in a mouse. You know, but I'd say on behalf of patients everywhere, we are so thankful we have doctors like you looking into this, and it's so exciting to hear about the research. You know, you're helping people like me across the world, and we're so thankful to all you who are doing this incredible research. So thank you so much, seriously, from all of us.
Well, thank you. That really that helps, because as you know, research it's a long process, and it's painstaking and it's difficult, and you know, hearing that kind of feedback from patients like you really keeps us going. So thank you for that.
Thank you.
So I think we've come to the end of our time here, and so you know, certainly from here in Baltimore and of course from New York as well, we'd like to thank all of you for joining us for World Encephalitis Day. We hope this has been an exciting and an interesting day and an informative day for all of you. And we look forward to continuing our work together on encephalitis, to supporting patients who have been affected. We're very thankful to the Encephalitis Society UK, to Ava Easton and others for putting this together. And thank you again.